Okay. All right, so we had ended with, and let's just do a quick review. I'm in heart failure. Give me a medication to help me with my heart failure.
ACE inhibitor.
You want to give me an ACE inhibitor? And what does an ACE inhibitor, name me one?
They Pril, anything ends in Pril.
Captopril, lisinopril. Okay, why do you like ACE inhibitors, Carly?
They diurese
Nope.
or no, they help with contraction heart. I don't know.
Okay, so remember that the ACE inhibitor, you guys, is the gold standard for heart failure because it decreases preload and decreases afterload. So those concepts, preload is that amount of volume that's coming back to the heart. And if it's a sick heart and you're dumping a bunch of volume in, it's certainly going to make it more difficult for that heart to pump. And then the afterload is the amount of resistance that we're pushing out the blood. And we don't want to have to work so hard. Like, we don't want to build that muscle up. We want to be able to get that cardiac output out. So ACE inhibitors do a really great job decreasing preload and afterload. One pill does both jobs. Okay, give me something else, somebody.
ARBs.
ARBs. Okay, so if I can't tolerate the ACE inhibitor, I could take an ARB, Sartans. And why do I like ARBs better than ACEs? I mean, me personally,
You don't have
No cough.
No cough.
Okay, so you definitely don't have that cough that's annoying because it's a different part of where angiotensin 2, it's on the receptors. It's not that ACE inhibitor. It's not that angiotensin converting enzyme. So we don't have the cough. So patients have a tendency to tolerate that a little bit more. What are some side effects to ARBs and ACEs that we worry about when we're talking to our patient and we're medicating our patient with ARBs? And
With this, we have to watch for angioedema.
big one, especially the ACE, but yes, you're absolutely right. The big swelling face. I think I had a picture of the lady's lips are all swollen. I actually had a patient trached because of the angioedema. Excellent. What else?
High potassium with the ACE.
And it can be, thank you, Nancy, it can be for the ARBs as well, too. So we definitely got to trend that potassium level. We got to definitely trend that potassium level. And along with the potassium level, what other levels?
your kidney functions.
Absolutely. BUN, creatinine, GFR, 100%, right? Because if my kidney function is not good, I'm not getting rid of that excess potassium. It's going to make things worse. All right, great. So you gave me an ARB, you gave me an ACE. What else?
You do a beta blocker.
You could. Remember, we don't want to give beta blockers early on in heart failure. Maybe later on if we had an MI and things like that, because remember the side effect of beta blockers, heart failure, right? So not in that acute phase. It could be later on, I'm going home. So anything that ends in OLOL. Give me some other side effects to beta blockers.
It's not good for beta 2 is not good for like COPD or asthma patients.
Correct.
Because it's not.
Isn't there something with hypoglycemia? Don't you
So
have to watch?
yes, definitely. You got to say to your patient, hey, listen, like you got to get a blood sugar because you're maybe not going to know those symptoms. It could mask those symptoms. That's exactly right, Courtney. That's exactly right. What else? You're going to take the heart rate. Nobody's picking orthostatic hypotension for any of these meds. I'm brand new to them, right? Could I drop my pressure real quickly? Yes. So your brain says brand new med, got to go back in. No matter if they've been on it a while or not, these patients are sick when they're in the hospital. You always go back and reevaluate if you drop that pressure after giving that medication. Any other meds?
What about a
Basics like diuretics.
pesticide?
All right, you hang a minute, Carly. Hold on to your answer. I think Nikki and somebody else said diuretics.
Excuse me.
Maybe Tori? I can't remember.
Yes.
Okay, good. Okay, so diuretics, what do diuretics do? And don't you say it takes off fluid. What does it decrease? What concept?
Like the reduced
Preload. It decreases preload. There you go. Yeah, where's my Tori? Tori decreases preload. It definitely decreases that amount of volume that's dumped back. Yes, you're supposed to diurese and go to the bathroom and lose excess volume. But you're really thinking about that sick heart. Doesn't want that fluid dumped back into the heart. The heart's like, wait a minute, too much is going on here. So we get rid of it. Give me an example of a diuretic.
Lasix,
Lasix. And what kind of diuretic is a Lasix?
a loop.
Okay, so what are we worried about side effects, guys?
Hyperkalemia.
Okay, thank you, Brianna, Mrs. Obvious. Okay, good. Yes, you do. She's right. You want to look for hypokalemia. Hypokalemia, because we excrete the excess potassium. Give me some other things that we're worried about.
Fluid
Tinnitus.
volume deficit.
Okay, so was that Christy? You said fluid volume deficit?
I said
No, that's-
tinnitus.
Okay, tinnitus, yes. And somebody who said fluid volume deficit?
Audra.
Oh, Audra, I didn't see your name pop up on my screen here. Okay, yes. So the smart nursing student goes back in and checks their vitals again, right? How do I know I'm fluid volume deficit?
If they're tachycardic and low blood pressure.
What else?
Could it be low sodium too? I don't know.
Sunken eyes.
Yeah, I'd like to look
skin.
dehydrated.
Sunken eyes, flat neck veins. So the sodium could be variable, you guys. If I dehydrate the patient and don't lose the sodium, sodium could be high. I could lose sodium with the diuretic as well. I could definitely lose sodium with the diuretic as well. So I always think of the sodium as variable. It could be high, low, or normal. Okay, so you gave me anything else with diuretics?
We give Didge.
You want to give some Didge? Who just said that?
It might have been me.
Who's me? I can't see where you're. Who?
Trisha.
Oh, sorry, Trisha. I couldn't, because it's usually when people talk, it pops up and I can't see it. Okay, so why do you want to give that, Trisha? Why do you want to give Didge? I'm not against it.
Because it's gonna.
What kind of drug
It's
is
a
Didge?
dilate, isn't it?
Nope, nope. What kind of drug is Didge?
It's a cardiac.
Cardiac glycoside.
Oh, all right. That's
Positive inotropic or whatever the heck
I
that fucking
know.
thing is.
Tropic. So positive inotropic. So here's what I want you to think about. When we give Didge, it helps the ventricle contract stronger. So positive inotrope helps with a better contraction, therefore a better cardiac output. So I'm going to contract instead of being a sick heart. Now I've got this really strong contraction and I get this beautiful cardiac output. Okay. So it's a positive inotrope and a negative dromotrope rate. So it drops the rate. So somebody like with AFib and a rapid rate, it'll help the heart contract better and help slow down the heart rate. Excellent. Any other drugs?
Vasodilators.
What kind you want to get, Bree?
Can we give like a nitro or something?
All right, let's talk about nitro. Is it on the venous side or the arterial side?
Venus.
Right, so it decreases.
The preload. Preload.
Yes, yes. Now, I think Elise said last time, well, it can drop the pressure too, and she's 100% right. So it does do a little bit of afterload reducer. But when we give that nitro, we really are in pulmonary edema. When I talked about that, when patients go to pulmonary edema, we really want to decrease that venous return, and that's decreasing the preload. So nitro does a beautiful job dilating on the venous side, which if I stretch out those veins more, there's less to dump back into my heart. The other beauty of nitro is it does a great job with dilating the coronary arteries. So I really perfuse the coronary arteries to get that blood to the coronary arteries as well, especially a sick heart. We want to get as much blood as we can get to that heart. Excellent.
Got to get it supply then for that supply thing.
Yes. Well, you're probably thinking more of the beta blocker supply and demand, but when we're thinking of nitro, we're really thinking of trying to decrease that preload and decrease
Ow.
the amount of volume that we dump back into the right side of the heart. I almost said left, the right side of the heart. So, yes, it can drop the afterload as well, but it's really for the venous side, to dilate the venous side to decrease the blood flow back to the heart. Heart can't handle a bunch of fluid dumping back. Okay. Excellent. Anything else? Anything else we want to talk about? Okay. All right, let's continue on then. Nice review of medications. All right, so we were talking about, and the primary treatment for heart failure I see most cases is medication, diet, exercise, activity, those kind of things. But there are some other things that we can do. Now, do you remember from Stephanie's lecture what CPAP is? Tell me, somebody tell me. Who usually gets this?
COPD patients, it's like continuous.
Sleep apnea patients.
That too.
Okay, so let's talk about that. What kind of heart failure do COPD patients and sleep apnea patients have? What side of the heart?
Right.
Yes. So why wouldn't we give somebody who has right or cor pulmonale, that's the other name, cor, C-O-R, pulmonale, P-U-L-M-A, now see, P-U-L-M-O-N-A-L-E, pulmonale. Never was in a spelling bee, never will be in a spelling bee. But continuous positive airway pressure helps keep the airway open, helps that patient breathe better, so they don't go into right ventricular heart failure because of their sleep apnea. So if they're diagnosed with obstructive sleep, OSA, obstructive sleep apnea, you'll see them on the CPAP, okay? This is a non-invasive way to ventilate a patient. So it's gonna help them get the volume down into, so this is like the step before intubating a patient. It's a non-invasive way to provide ventilatory assistance. A non-invasive way. That means I'm not putting a breathing tube down. We're gonna do that next semester. And the beauty of CPAP is it helps decrease preload and afterload. And that's really, if you think of those right-sided heart failure patients, those right, don't get me wrong, you'll have a left-sided heart failure patient needs a CPAP as well too, because they're in pulmonary edema and we need to help ventilate the patient. CPAP can non-invasively ventilate the patient, not give them oxygen, ventilate, volume. There's a difference. I can give oxygen through a nasal cannula, through a mask, but CPAP helps with giving them volume. Okay, next is the cardiac resynchronization therapy or biventricular pacing. This is great in a patient who has an ejection fraction of 35% or less, 35% or less, really, really sick heart, okay? End stage heart failure. And it helps the ventricles contract, so it increases the ejection fraction and the cardiac output. So they're pacing both ventricles, hence why it's called biventricular. It helps the ventricles contract to increase the ejection fraction and increase the cardiac output. Again, for a really sick heart, ejection fraction less than 35%. And we would see that on their echo. Remember, you need to know that echo because that echo is going to tell us what that patient's EF is, or if they have a heart cath. CardioMEMS is a picture next slide, so don't get crazy about it, but it's about the size of a quarter, which I find fascinating. No one's ever going to ask you that, so don't obsess about it. But what it is it's inserted in the pulmonary artery. Remember, the pulmonary artery comes off of the right ventricle. Pulmonary artery is the only artery in the body that carries deoxygenated blood. So we pull that volume out of the right ventricle, go through the pulmonary artery, it has to go to the lungs to pick up oxygen. This measures the pressure within the pulmonary artery, and they can tell if the patient is fluid overloaded or not. So it gives this readout, and honest to God, no one's going to ask you to interpret the readout. I'll show you in the next slide. But it gives this readout, and the cardiologist can call the patient at home and say, you need to take an extra diuretic today. You're up in volume. So it's a really nice way to tell us fluid volume status. It's a great way to tell us fluid volume status. And they can say, hey, so we don't have to keep getting readmitted back to the hospital because I'm in heart failure and excessive fluid volume. They can monitor this through this CardioMEMS system. And I, honest to God, have never taken care of anybody that's had one, but it's fascinating. So I'll show you a picture in the next slide. And then the last is gene therapy, and I have never taken care of anybody with gene therapy. It replaces the damaged genes. So it's very investigative, Maybe you might go to like a big research center, Duke University or something like that, and perhaps they're doing gene therapy. I have never taken care of a patient who had gene therapy, but it is something on the horizon. So maybe you might see it if you decide to leave little old Youngstown. Now, don't obsess about the slide. I just want to show you how fascinating this is. It could see, this is the pulmonary artery right here, and it sits right in the pulmonary artery and it says, hello, you have too much volume or you have too little volume. And down here, this is the readout that the physician gets. So they could call a patient at home, this little fancy pillow over here in this monitor. They can call the patient home and say, hello, your fluid excess, take an extra diuretic, tell me what your weight is or whatever. It's a way to try to prevent recurrent admissions. It's a way to try to prevent people having to keep coming back in because they're in fluid volume excess. Okay, heart transplantation, best choice, you get a new heart. Certainly, you have to be criteria for that. You know what I mean? So, and then you got to get on the wait list and all that fun stuff. So in the meantime, you might take care of patients with a VAD, a ventricular assist device. And I have a picture in the next slide, but it actually is a pump that works to help with the patient's heart, and it helps with cardiac output. This is a bridge to transplantation. So maybe I got put on the transplantation list and they give me this ventricular assist device until I get my new heart. Okay. Other surgical therapies, they could do a partial left ventriculectomy. They'll actually cut out like a wedge of the heart, and it provides like a sort of normal shape of that ventricle, because remember that ventricle gets stretched and enlarged. The other one is the endoventricular circular patch, and that provides a normal shape as well too, and I'll show you a picture of that coming up. This Acorn cardiac support device actually looks like your heart is in a set of TED hose. So it keeps that shape and helps with the function as well, and it prevents overstretching of the ventricles. It prevents overstretching of the ventricles, and it's a mesh jacket placed over the ventricles. That's what the Acorn cardiac support device is. And then the MyoSplit is electrical stim, and it helps with more normal shape and function as well too. I have not taken care of anybody. The VADs, we usually send them up to Cleveland Clinic. I have not had a patient who had a ventricular assist device implanted. They'll go to Cleveland Clinic, and if they're on a transplant list. Complications are bleeding, infective endocarditis, and dysrhythmias and stroke. Okay, we're putting a foreign substance in a patient, so you really want to worry about that. So here it is. Here's the pump. So left ventricular assist device. It's helping the left ventricle pump out to the body. So it's going to help with cardiac output. Pretty invasive. Again, a bridge.
Really that big?
So that's inside, and honestly, I don't know the size. That's a pretty big image. It almost looks bigger than the heart, doesn't it?
Yeah.
I've never seen one personally, but I imagine they probably did it to scale. This is on outside of the body that they're carrying like a battery pack, and this is all implanted. This is attached to the left ventricle, and this is sewn into the aorta. So it's boom, it's helping with cardiac output because this is a very, very sick ventricle. I imagine it's probably close to that size because it's doing comparable to the size of the heart. It's really taking the place of that left ventricle because that left ventricle is so sick. Here's the patch. Okay. So we're going to try to make that normal shape, increase the function. And this is, doesn't it look like a, I was going to say a jock strap, but yeah, I mean, doesn't it? I mean, it really does. So it's providing support. Okay, it's providing support so that the ventricles don't overstretch. It's providing support so that the ventricles don't overstretch. Okay, so some interventions. So energy management. So you've got to pace activities. You can't go into somebody with significant heart failure and say, all right, we're going to get washed up. We're going to therapy. We're going to walk down the hallway. We're going to go eat your breakfast. We're going to do. So you have to pace their activities and really gauge it on what kind of shortness of breath they have. You know, if you're just having them wash their face and they're really short of breath, you got to stop what you're doing. So pace your activities. The other thing is cardiac rehab. I know you guys know where that is. It's down on the first floor of our lovely building. And of course, I don't think the people in cardiac rehab look like this little cutie in this picture, but so they are monitoring the patient, getting their vital signs, putting them on a treadmill and stressing the patient and getting them to exercise and slowly increasing. We don't just say, get up on there and run 15 miles an hour and run for, 5 miles. So it's slowly increasing their level that they can tolerate. So they're safely being monitored while they are exercising. Managing or preventing pulmonary edema. So that's the big complication, because then we start getting into the emergency situation, because pulmonary edema, they'll start coughing up pink frothy sputum. Okay. And there's a lot, I mean, they have crackles all the way up. So if we go in and we notice just crackles in the bases and they're short of breath at rest, and they're maybe a little bit confused because they have decreased cardiac output, you want to act on that now rather than later. Do not wait until they have crackles all the way up to their chin and they're in full-blown pulmonary edema. You want, and what happens in pulmonary edema is that fluid leaks across the pulmonary capillaries into the lungs. Fluid leaks across the pulmonary capillaries into the lungs. So when you listen, you hear all that fluid in there, you're going to hear those crackles.
Maureen, I'm sorry, I gotta.
Yeah, go ahead.
I know this is gonna sound silly. Everybody probably gets it, but I don't. How is COPD right-sided heart failure if it's pulmonary and left side has to do with the lungs?
Okay, so right, left-sided failure, because I don't have a forward cardiac output, it's backing up, and we eventually back up into the pulmonary system with a failing left ventricle, because we want forward flow. If we don't have that, because my left ventricle is stunned, I had a heart attack, it's not contracting, it's going to back up into the lungs. With right-sided heart failure, because the lungs are damaged and COPD causes chronic changes and fibrotic lungs, there's pressure within that pulmonary vasculature. It backs up into the pulmonary artery, causes pulmonary hypertension, and then backs up eventually into the right ventricle. So if you know the flow through the heart, just think of which way it's going backwards. So if I have significant lung disease, it's going to back up into the pulmonary artery, and that pulmonary artery is connected to the right ventricle.
Okay.
Does that help, Tammy?
Yes, it does. Thank you.
Okay, you're welcome. Yeah. Now, don't get me wrong. I want you to really think about this. The left-sided heart failure patient can eventually have you can eventually have biventricular failure. Do you guys understand that? You eventually can have both ventricles failing, because I'm so sick that it backs up, backs up, backs up, backs up. But if I'm purely like a COPD patient, I'm going to start with cor pulmonale or right-sided heart failure. And if I have an infarct on my left ventricle, I'm going to start with left-sided. Okay. That's why we differentiate between the two. More often than not, by the time that they're significantly ill, it's both ventricles are failing. I hope everybody gets that. Okay. But like if I'm sitting here and I end up having a huge left ventricular infarct, I'm going to manifest all of those respiratory symptoms, pulmonary edema, crackles, all of those, because my left ventricle has just failed. Okay. If I have a massive PE that's blocking my pulmonary artery, blocks the pulmonary artery, I can't get back. I can't get the blood out of the right ventricle. That right ventricle enlarges, and then they have right ventricular failure. So always think about where the problem is and think backwards.
Dr. Comer, I have a question.
Yes.
In our PowerPoint, it says something about with the left-sided failure that you don't always have chest congestion. Can you explain that to me?
So you can have left-sided failure that, I mean, more often than not, you're going to. But you can have failure where the blood is just not leaving the ventricle or the atrium. It's not backing up into the lungs. Cardiac tamponade is something I'm thinking of where I can't contract at all and nothing's moving. So that would be probably the most common reason why. More often than not, when we have left ventricular failure, you're going to have some crackles. More often than not.
Thank you.
You're welcome. I hope that answered.
Yes.
Okay. All right. So we want to sit them up. Supine, no good. No good. Do not lay these patients down. They can't breathe. You want to sit her up. See how nice she's sitting up in actually a high Fowler's. You're going to add oxygen to them. Nitroglycerin because it decreases.
The afterload.
Sorry.
The preload. I don't know why I keep on.
Preload. Yes, thank you. We're going to give a diuretic because we got crackles all over town. Okay, so we're going to give diuretics. We're going to give it IV. This is where your brain needs to think, you guys. I don't walk in with a little Lasix 20 milligram tab and say, here you go. This is an acutely ill patient. We want it in their system. We're not waiting for them to digest the pill, go to the liver, first bypass and all that stuff. Your brain says, I got to give things IV. Okay, this is an acutely ill patient. You want to give morphine because morphine does what? And don't say decreases pain. That's not why we're giving it in pulmonary edema.
Vasodilates.
And what does it do? So it decreases
Volume.
Respirations.
no. Well, it does do that, and that's always bad. But the purpose of giving morphine. for
Preload,
pulmonary-
decrease the preload.
Yes. This patient has problems with volume again. So morphine is a great drug. And the patients always go, well, I'm not having pain. I mean, sometimes they will. And I'm like, no, that's not how we're doing that. We're giving it because it decreases preload for pulmonary edema. Don't get me wrong. We give morphine post-surgical and all that stuff. But if somebody's in pulmonary edema, it's not for pain. I might help them with their pain, whatever pain they have, but it's really to decrease the preload. And then you constantly got to be assessing. One of the things in that high Fowler position, I want you to think about this. If the patient is able to do this, sit them on the edge of the bed and drop their feet down. Why am I doing that?
To help perfusion to the lower extremities.
Circulation.
What am I trying to decrease?
Orthostatic hypotension.
What am I trying to decrease?
The venous return.
Yes, preload. So if I drop my legs down, isn't it going to make it be harder for that all that excess volume to come back to my heart? So if they're able, drop their feet down, put them in a high Fowler, sit them on the edge of the bed, have them have their legs down because it's going to decrease preload. You put those legs up, all you're doing is increasing that venous return and you're dumping more fluid back into the heart and making them worse. Now, don't get me wrong. Not every patient can sit on the edge of the bed with their legs down. Okay, when would you hold, this is now smart nursing students, when would you hold the nitroglycerin or the IV diuretics? You're ready to go in.
Heart rate under 60.
Heart rate.
Not heart rate, not heart rate.
Blood pressure.
Yes. Blood pressure, right? Because we know that diuretics, if I pull off excess volume and my pressure's already 70/40, you're going to tank them out. Do you guys see that? You got to think. You got to think before you give these drugs. Anybody can give these drugs, but your brain says, boy, I should probably assess the vitals on these patients before I give these meds. Is it safe? Is it a safe process that I can give this nitro for whatever, or the morphine, even the morphine, same thing, drops the pressure. All right. So very important that you evaluate prior to.
Okay,
What-
so
Go ahead.
so even though that they have pulmonary edema, and you said if you give them one of those meds, it could drop their pressure. Now, even though they have edema, could they be hypovolemic?
Heck yeah. Where's all the fluid? Where
It's
is it?
in their heart, around
It's
their
not
heart.
in their heart. It's in their capillary. It's leaked out of their capillaries in their
Heart
lung, and
spacing?
now they're filling their alveoli, and hence the short of breath. Absolutely can be intravascularly depleted. This is why a patient needs to end up in the ICU. They're acutely ill. Let's get them turned around. Let's get them fixed and then transfer them out. Absolutely 100% can be volume depleted. Yes.
Okay, I just didn't want to sound dumb.
Mhm.
Hey, Lorraine. So like when they are in pulmonary edema and say their blood pressure is low, what will we do?
Okay, who asked me? Because I'm trying to see who's talking.
Abby.
Abby, okay. So Abby, it gets a little more complicated, but we would add medications to help bring that blood pressure up. And those are IV medications you'll learn about next semester. So again, this is why I'm telling you guys, these are really sick patients. These are patients that need to be in the ICU. So there are medications that we can give to vasoconstrict to help bring the blood pressure up.
So if their like potassium level was already low
Mm-hmm.
and you're giving like the rapid IV diuretics, how would you make sure you're correcting the potassium or maintaining it? Is that something you would consider like after you get them out of the acute phase or?
Oh, no. Here's the thing. My brain says, oh, I'm giving a loop diuretic. I already know the K is going to be low. So you already said one thing that's important. You already knew it was low. So your brain should be, I'm going in with the Lasix or Bumex, and I should have a potassium in my hand, IV, because I already know their potassium's low to begin with, and now I'm giving them something else that can make their potassium go even lower. So a lot of times I'm giving Lasix and potassium chloride together.
Okay, thank you.
Not mixed together, but at the same time. So I'm already anticipating that, and I'm already having a conversation. Like the renal docs that I work for, if they give Lasix or diuretics, they get a BNP at 4 p.m. If they haven't ordered it, something's wrong. So you as the nurse go, hey, whoa, pump the brakes. I just gave diuretic. Don't you want to get some more lab values? So you constantly are looking for those. Do not let it go. I mean, I had a lady with a potassium of 2.4. I think that's the lowest I've ever seen. No, 1.8 was the lowest I've ever seen. And that causes more cardiac issues and the heart to be more stressed to make the heart failure even worse. So you want everything to be ideal if you possibly can. So you're definitely going to anticipate giving potassium at that time as well. I hope that answered the question.
Absolutely. Thank you.
That was a long way to answer that question, but I hope you were thinking of that. Okay. Home care management. So we got to go through those dietary restrictions. So remember what I said about heart failure patients, there is a ton of teaching. So that little MAWDS, MAWDS, you might want to think about that and get that in your brain. Let me tell you what that stands for. M is you better teach me about my medications. Okay, whether it's ACE inhibitor, an ARB, or all those ones that you were just talking about. A is what kind of activity am I allowed to do? Am I going to cardiac rehab? Do I walk at least 3 times a week? Am I getting 15 minutes a day or whatever that activity the physician says and whatever I can tolerate? If I notice that I used to be able to walk half a mile without getting short of breath and now I'm getting short of breath, there needs to be a phone call. W, they should weigh themselves every single day. Remember what I said, 1 to 2 pounds overnight, 3 pounds or greater in a week, we got to make some phone calls. So they should be weighing themselves daily. D, diet. What kind of sodium and fluid restriction are they on? Are they on a 1 liter fluid restriction? Are they on a 2 gram sodium restriction? Again, not for you to decide, it's for you to enforce. It's for you to teach them about, okay? And then last is symptoms. You know, shortness of breath at rest. Are they coughing? Are they getting up in the middle of the night, peeing a lot? So really paying attention to those heart failure symptoms. You know, give us a call if you notice that you're peeing 3-4 times a night. That's not normal, okay? The other thing is there's a folder, and I used to give to my students when we went to 6 West Extension, but that's been a COVID unit. So we haven't been there, but there's a great heart failure folder that every patient gets. And it has everything that I just mentioned, the medications, activity, weight, diet, all in one place. And it's a lot of information, so it's a pretty overwhelming for the patient. But when they go home, they can just refer to that. So maybe they want to think about their diet today and really read up on that. So there's a heart failure folder. There is a heart failure educator in the hospital that goes around and specifically does teaching. So your brain says, if we hired somebody to specifically talk to patients about heart failure, that's got to be a big problem. Okay, so we do have a heart failure educator who will go around and teach the patients, okay? And then finally, any kind of resources, American Heart Association, are we going to cardiac rehab? Is there anything else, a support group? What kind of resources can you provide? Indications for worsening or recurrent heart failure. Remember I said big problem with readmittance. Rapid weight gain, rapid weight gain. So 1 to 2 pounds overnight. We don't wait until you gain 5, 6, 10, 12 pounds. And then 3 pounds in a week. Rapid weight gain, got to call the doctor. Decrease in exercise tolerance. So are they able to only take 1 flight of stairs and then they have to sit down? And they notice that they're not able to do as much. My father said, oh, I used to be able to garden for hours and now I have to sit on a stool and take a break. And then I can go back to work and take a break. So looking at, are they tolerant or are they decrease tolerance for activity? Cold symptoms, if they last longer than 3 to 5 days, that could be that they're in heart failure. So that cough, that shortness of breath, those kind of things, if they last longer than 3 to 5 days, they should call. Excessive awakening at night to go to the bathroom, not a good thing, unless they took their diuretic at 10 o'clock at night, which is not a smart thing as well. So we're going to educate our patient to take diuretic earlier so it doesn't awaken them at night. Do they have dyspnea or angina at rest? And are we seeing an increase in edema in feet, ankles, and hands? The other thing is patients will say, oh, my pants are getting tight. And that could be fluid around their waist too. They can get ascites. So really paying attention to my clothes are getting tight or my shoes are getting tight or my socks have left lines in my ankles. So really paying attention to any kind of changes in the edema. All right, questions on heart failure, because we're going to move on to the inflammatory infectious stuff. All right. I want you to put a note here. If you look in your chapter, and I don't know if you guys read your book, but your book is pretty easy to read. I just read it again today. We were going to skip over the valvular disease. So please don't email me and say, are valves on the test? Valves are not on the test. Valves are going to be next semester when you come to critical care. We're going to talk about valvular heart disease next semester. So you need to skip over that section. We don't want to talk about mitral valve stenosis or regurgitate next semester. We do want to talk about inflammation and infection, and one of the big ones is this infective endocarditis. So that's a damaged valve up here. Very common in IV drug abusers or patients who've had a previous valve replacement, somebody who's septic who are throwing little clots, or if we have some sort of structural cardiac defect. How the microorganisms can get in is oral cavity, could be due to dental procedures. Are we drilling a teeth and those little plaques are breaking off and it's getting into our bloodstream? Dental procedures, skin rashes, lesions, and abscess. Perhaps I got a tattoo and I have an open area there. It can get through there. It's body piercings, infections, or any type of surgery or invasive procedure. Now, I worked medical intensive. My most common reason why I've seen infective endocarditis is IV drug abusers. Dirty needles, sharing amongst people. That was my most common. And that's just because of maybe the nature of the unit that I was on. The 2 microorganisms that are most common with infective endocarditis, strep and staph. So strep and staph. And we have both of those on our skin. So if my skin integrity is not intact, it can get in that way. Or if I use a dirty needle and I've got bacteria on my skin, I can get it into my bloodstream that way. So what is the assessment findings or clinical manifestations with infective endocarditis? The top 3, so put a little like maybe triangle or whatever, the fever, the murmur, and heart failure. Those are the most kind of common that you'll see. Patient will come in, they'll have a temperature remember that older patients may not be febrile because they're normally a lower temperature to begin with. So maybe they were 96 something to start, and now they're 99. That's a temperature for them. Okay. So very important. Sorry, just trying to let somebody in. Very important that you pay attention, though, even though your older adults may not be febrile, that that you pay attention to, did we see a new murmur? So you go in and you listen to them and you're like, well, that wasn't there yesterday. Did we find this new murmur? Okay, remember, murmur is a soft, blowy sound through a really bad valve. And if there's vegetation on the valve, that valve is infected, things are built up, vegetation on that valve causes turbulent blood flow, you're going to hear that murmur. And then signs and symptoms of heart failure. Do they have crackles? Do they have shortness of breath? Are they getting up in the middle of the night? Also, do they have an S3 or an S4? And the vegetations, that's what I'm talking about, is that we can throw these like little clots, and then they can like sit on the valve and cause that valve to be infected. Okay. Osler nodes are on the palms of the hands and sole of feet. I have a picture of that coming up in the next slide. Janeway lesions, they're flat and red macules on the hands and feet. I'll show you that. They can have neurologic changes, change in the mentation. Petechiae, in particularly, you want to look at their mucous membranes, maybe their palate, and their conjunctiva or conjunctiva, whatever you want to call them. Little red pinpoint dots, petechiae. And then the splinter hemorrhages are these long, almost black-like lines in their nails. And I have a picture of that in the next slide as well, too. Very characteristic. Plus, if you get a history and you know that they're an IV drug abuser or they've had a valve replacement, you really start to suspect infective endocarditis. So, and I have a better picture coming up. Please do not memorize the Duke criteria for diagnosis. It's just saying that you have to have 2 of the major ones, or 1 major, 3 minor, or 5 minor. I don't care about that. Just know those symptoms: Osler nodes, Janeway lesions, splinter hemorrhages, because you're going to walk in the room and you're going to assess the patient. You're going to see these on the patient. You should go, oh my God, endocarditis. Very important that you pay attention to that. Please do not memorize this Duke criteria. All right, let's talk about the pictures I have here. So this right here is a splinter hemorrhage. That is a splinter hemorrhage. Okay. These are Osler nodes. Okay. These are Janeway lesions. Okay. And these are little petechiae in the conjunctiva. So you pull down that conjunctiva and you can take a look in there, and those are the petechiae. Very characteristic. Now, honest to God, don't look at your nails, and if you see something like that, you go, oh my God, I think I have endocarditis. You can bruise and cause, ecchymosis underneath the nail bed as well too. But looking at all of these, do you have a fever? Do you have a murmur? All of those play a part. Okay. So what is the diagnostic? Most reliable, these top 3. So put them all together. Positive blood cultures times 3. So they're going to draw 3 blood cultures. A new regurgitant. So you're going to have swoosh, swoosh, murmur. And then evidence of endocardial involvement by 2D echo or TE. They'll actually see the vegetation flopping around on the valve. They can actually see the vegetation flopping around on the valve. It's quite interesting. I've seen it. It's quite interesting. You can go to Heart Catholic and take a look at the valve and see how well the ventricle is functioning. The WBCs will be elevated because we're infected, and your SED rate. I want you to add CRP there as well, because that will be elevated in inflammation. And decrease in hemoglobin and hematocrit, it could be because maybe the red cells are rupturing because of the turbulent blood flow through the murmur. I don't see active bleeding in an infective endocarditis patient, I really think it might be like rupturing of blood cells or some sort of damage in there. Okay, we're gonna get a throat culture because we want to look for strep. Because remember what I said, strep is one of the big causes. So maybe somebody had strep infection that was untreated and it got into the blood and then it infected their valve. So we definitely want to get a throat culture to look for strep. Okay. All right. So non-surgical, and this is the mainstay treatment. I just took care of somebody a couple weeks ago who needed IV antibiotics for 2 to 6 weeks. Usually outpatient. So what they'll do is place a PICC line because the PICC line can stay in up to 2 years. Most don't, but they can. And they'll get antibiotics, IV antibiotics for 2 to 6 weeks. The problem is, and he was a drug abuser, so we had to place him inpatient so he didn't use that PICC line to inject drugs in. So this patient had to be placed into a nursing facility to get the antibiotics for the 6 weeks, and that they didn't use that line to inject drugs in. And actually, two nursing homes refused this patient because they escaped, and they said they're too much of a risk for our nursing home. So it was hard to get this patient placed because nobody wanted to take that risk of her being a flight as well. Activities balanced with adequate rest. So making sure that you pace their activities as well. If it's significant enough, I had somebody go back and have a valve replacement because it was so infected that they went down to open heart and had that infected valve removed, and they replaced it. You can repair the injured valves. If there is an abscess, you may drain it. If there's an infection there, they'll go in and actually drain those abscesses as well. Most common right here, antimicrobials, depending on the source. Most of the time we think it's bacterial, strep and staph, but it could be fungal, it could be viral. So really important that we know, that's why we culture, that's why we know exactly what microorganism causing the infective endocarditis. All right, preventative. So a lot of times, and I have mitral valve prolapse, and they used to tell me I needed to take antibiotics prior to getting any kind of dental procedure. And then they sort of stopped doing that. I guess mine wasn't significant enough, so we stopped doing. I haven't had antimicrobials probably 20 years before, and I get my teeth cleaned every 6 months. Also, before and after tonsillectomy and adenoids, so TNA, surgery involving respiratory mucosa, whether we're having diagnostic procedures such as bronchs or cystoscopy, or any surgery involving skin infected skin or musculoskeletal tissue. So we're going to give antibiotics before and after. Good oral hygiene. Remember, the plaque can build up, and if we have poor oral hygiene, that plaque can break off and get into the blood system, and it can cause vegetation on the valve. So making sure that patients are brushing their teeth, that they're using mouthwash, nail biting, dirty in your mouth, none of that. Body piercings, branding. I've never had a patient who was branded. Tattooing, yes. So making sure that if you are somebody who has valvular disease, being very careful about tattooing. And I don't know what the Heart Association's recommendations are. If you want to get a tattoo and you have a bad valve, what they recommend. That'd be a question for cardiology. Minimize acne outbreaks, because that is that staph and strep in there. So making sure that we don't have pustules and the skin integrities broken on the face. And then IUDs are invasive. So again, though anything invasive in the body can throw clots and do all kinds of fun stuff. So not using IUDs and some other form of birth control. All right, let's take a break here. It's 6:37. Let's come back at 6:50, and then we'll pick up with pericarditis. I'm going to pause the recording for a minute. So Tricia asked me a question, and I'd like to answer it for everybody. So she said, when giving a diuretic, you said you give potassium to prevent potassium level from dropping. Could you give a potassium sparing diuretic instead of a loop and to prevent it from the potassium dropping? So a couple things. There's a couple things in that question. One is, if I'm a chronic heart failure patient and I know I'm going home on diuretics, yes, Tricia, that's a good choice to give them a potassium sparing. But when I was talking about the pulmonary edema patient who's in an acute situation, we can't give potassium sparing diuretics IV. They're only oral. So it wouldn't be a good choice for somebody who's acutely ill. But if I'm a chronic heart failure patient, aldactone is a great drug that patients will go home on. Yes. And then we don't have to chase that potassium as much. On the flip side, we have to worry about the potassium going too high with potassium sparing diuretics. So you got to look at it both ways. But when they're acutely ill, we're going to give it IV. And I don't know of any potassium sparing diuretic that's IV. I only know the loops as IV. Tricia, did I answer your question? I hope. All right. Silence. All right. So we'll talk a little bit about pericarditis. And we'll see how far we get today. We're doing great time-wise, so we're doing okay. Okay, thanks, Trish. All right, great. All right, so let's talk about pericarditis. So we're talking about that pericardial layer around the heart that's inflamed, okay? So that pericardium is inflamed. So acute pericarditis caused by pericarditis to develop. So if you look at the heart here, this blue area, that's fluid. So when we talk about pleural effusions, fluid outside, it's not within the lung, it's outside compressing the lungs. This is now compressing the heart. So pericardial effusion is fluid collecting around the heart. And what you'll hear, if you remember way back in 110 when we talked about pericardial friction rub, that is the hallmark of the condition. You'll hear this leather grating rub. And the way that we tell, if you remember us from checkoffs, we said, hold your breath, and if the sound is still there, it is a pericardial friction rub. If it goes away, it's a pleural friction rub. So if you have your patient hold their breath and you still hear that squeaky screen door that they refer to here, that is a pericardial friction. Those are the layers of the heart rubbing up against each other that are inflamed and making that sound. It's a terrible sound. Present in systole and diastole, so you'll hear it going back and forth during lub and dub. I want you to take a, this is a normal chest x-ray. So you can see the heart here. This is the outline of the heart. Look at this. Look at the size of the heart over here. This is with fluid around the heart. Huge, huge, okay? And pericardial effusion, the issue with that is it could constrict blood flow because that fluid is compressing on the heart. It's like sitting on somebody's chest and not being able to expand and contract. So think about that. So that excess fluid is causing restriction of movement, okay? So you could have a small pericardial effusion and not have significant problems with cardiac output and such, or it could be significant enough that it's an emergency. So it just depends on the amount of fluid that's around the heart.
Now, I have a question about that picture. That is so big that with the fluid being around the heart and it making it bigger, does it compromise the other organs that are around there? Like
I mean, it could compress the lungs. It could compress the lungs. It's not going to get down into the colon. Do you see what I'm saying? Because it's in the chest. But you're definitely right that it could impede And when a pericardial effusion is significant enough, we're going to surgery. So I'll talk about that when we get to that, if it's significant enough. Not all pericarditis patients need to have surgery. So I just want you guys to understand, this is a really bad case scenario. Not all pericardial patients need to have surgery. All right, so what do we look at? What do we see? What clinical manifestations? Substernal precordial pain, radiating to the left side of the neck and shoulder or back. Grating, oppressive pain. It's terrible pain, terrible pain. And it's aggravated by breathing, coughing, or swallowing. And particularly when they take a breath in, it hurts more. It hurts more on inspiration. Hurts more on inspiration. Pain worsened by supine, so you want them to sit up and lean forward. My boss's son actually had this, and he said it was some of the worst pain he's ever endured. Okay, so they'll complain of pain when they lay down, so you're going to find them sitting up and kind of leaning forward. They'll have pain up the left side of the neck and the shoulder and the back. You're going to hear a pericardial friction rub in the left sternal border. Okay, and then you want to, the way you diagnose is you have presence of two of the following. Do I have chest pain? Do I have a pericardial friction rub? Is there change, ST elevation in all EKG leads, or PR segment depression? So if you remember, the PR segment is the atrial contraction, ST elevation is repolarization. So is there ST elevation in all EKG leads? And I'll show you one in a minute. Or new or worsening pericardial effusion. And the way that we can see that, you saw on the chest x-ray, CAT scan, we can take a look at that. So now we notice that there's fluid around the heart. So presence of two. So if you look here, and remember that you should be a straight line all the way across, and you see how this is elevated. This is way elevated. Those are your fireman hats. Elevated here. So we have all this ST elevation in all of the leads. Now, no one's going to ask you to interpret, AVR, AVL, and AVS this semester. You'll learn about it next semester. But just know in your mind that one of the diagnostic criteria is ST segment elevation in all of the leads. So you as the nurse are going to get a 12 lead and send it on to the cardiologist and say, here you go, and let him make the interpretation. But once you start reading with it, rhythm strips, you'll know what ST elevation looks like. So you'll be like, huh. All right, other manifestations. They're going to have a fever. They're going to have an elevated white blood cell count, so leukocytosis. Elevated SED rate or C-reactive protein, remember, with inflammation. They're certainly going to feel crappy, so they're going to be malaise. They're going to have muscle aches, myalgia. They're going to be tachycardic, and they may present with signs of heart failure if it's constrictive. Remember I said, if it's significant enough, because now I'm not getting a cardiac output. My boss's son did not have signs of heart failure. He just had that terrible, he had a fever, the white cell count, all the blood markers, and just fatigue and malaise and tachycardia. Okay. You may see also, you can add to this, is they might get cardiac enzymes. So a CK and troponin may be elevated as well. Cardiac enzymes, meaning a CK and troponin, may be elevated as well. Chronic or constrictive pericarditis, adhesions develop. Now take a look at these ventricles, how large they are. And then those layers start to stick together and it restricts ventricular filling. So that is signs of diastolic heart failure. Because remember, diastolic has to do with the filling and systolic has to do with the ejection. So diastolic heart failure, okay? How we treat this is pericardectomy. So they might go in and do a pericardial window. So you might hear them say, oh, he's going for a window. It's not literally a window, but they're going to cut into a section to allow the fluid to drain into the lymphatic system and be reabsorbed.
Dr. Comer,
yes.
Would the BNP play any role in the labs with the pericarditis?
So, I mean, if you're really looking for them to be in heart failure, now remember that my boss's son didn't have signs and symptoms of heart failure. But to answer that question, yes, if we really think that this patient may be going into, and that may be the decision whether to go to surgery or not. Now this patient's manifesting signs and symptoms of heart failure. So yes, it could definitely be something that they would consider getting on the patient. I don't disagree. Not diagnostic for the pericarditis, but diagnostic for patients going into heart failure. I hope that answered it. Okay. So what are they? Oh, there's your diastolic heart failure. All right, symptoms of diastolic heart failure. So we're going to have edema, fatigue. We're going to have pain. Again, aggravated by breathing, more so on inspiration or coughing or swallowing. And definitely when they lay down supine, way worse. They're going to want to sit up. They're going to probably sleep in a Fowler's or high Fowler's position. You're going to hear a rub at the left lower sternal border. So you're going to hear that friction rub at the left lower sternal border. So we're going to do a CAT scan. We're going to see a thickened pericarditis. We're going to do an echo to show the effusion. 12 lead, a lot of times they'll show atrial fib. Remember that rapid rate, that tachycardia, so they can have a rapid rate with atrial fib as the rhythm. And then elevated white blood cell count, that leukocytosis. So what are we going to do for these patients? Well, one is mainstay treatment is NSAID. So you might get big doses of ibuprofen. If it works, that's great. Indomethacin is not the drug of choice. So that's an NSAID, but it's not the drug of choice. May decrease coronary blood flow. And we don't want to do that. We already have issues of maybe some constrictive pericarditis. So not a drug of choice for pericarditis. Colchicine, it could be given instead of NSAID if the NSAIDs, maybe they don't tolerate NSAIDs, they GI bleed or whatever. And then steroids are added if refractory to both of those meds. And refractory means they don't work and no bacterial growth. So if we don't have an infectious and only an inflammatory process, we're going to use steroids. Let me say that one more time. If we do not have an infectious process, steroids are great. If we do have an infectious process, steroids could exacerbate and make that infection way worse, okay? You want to avoid any blood thinners or aspirin because it increases the risk of tamponade in these patients. So you want to avoid aspirin or anticoagulants because it can increase the risk of tamponade in these patients. Patient may have to be on this colchicine for 3 to 6 months to prevent reoccurrence of pericarditis. And then depending on the cause, if it's bacterial, we're going to need antimicrobials. If it's an infectious process, bacterial, we're going to need antimicrobials or antibiotics. If it's a uremic pericarditis, and I'll talk about that next semester when we get into renal, but the BUN and creatinine levels, if they're critically high, somebody in acute kidney failure, those uremic toxins can cause inflammation of the pericardium. So that's called uremic, U-R-E-M-I-C, uremic pericarditis. And the way that we would help that patient with uremic pericarditis is dialysis. Don't see it that often because we dialyze before we get to that situation, but I guess somebody could be at home and stay at home too long and end up showing in the hospital that way. So uremic pericarditis has to do with elevated BUN and creatinine levels, and they're going to need dialysis, okay? Chronic pericarditis may need some radiation. So chronic pericarditis may need some radiation. I've only seen the acute in my unit. I didn't work in a specific cardiac unit, so I maybe downstairs when you guys go to CVIC, you might see it, but I've only seen the acute pericarditis. All right. So the biggest complication with pericarditis is tamponade. So we talked earlier on that the CAT scan or chest x-ray will show, or 2D echo will show that pericardial effusion. And if it gets significant enough, it can compress the heart. So if you look at this picture below, you see that fluid that's sort of obstructing and it's compressing the heart, and it's not allowing two things. One, decrease in ventricular filling. So then we're not getting enough out, which means we're not getting enough back in. So things aren't moving. So tamponade, like I always think of things as kind of at a standstill. That is emergent. That is emergent. Cardiac failure, shock, and death. Now, and I'll tell you a story. Well, we'll go through the symptoms and then I'll tell you a story what I got to see in the ICU. So the classic symptoms are hypotension because decreased venous return. So they have a really low blood pressure. I'm not getting blood back to the heart. Therefore, I'm not getting a cardiac output. Patient is hypotension. Neck vein distension because the volume's out there, things are backing up, and I am not getting that blood back into the heart. Muffled heart sound. So that means I have a really hard time hearing the heart sound. So that S1 and S2 that you normally hear, lub-dub, lub-dub, very, very hard to hear, hence the word muffled. That's called Beck's triad. Patient's hypotensive, they got neck vein distension, and I can't hear their heart sounds. Suspect cardiac tamponade. They're going to be tachycardic. Paradoxical blood pressure, it's called pulsus paradoxus. It's in your book. But what happens is your systolic blood pressure on inspiration will be lower than expiration. So your blood pressure fluctuates with inspiration and expiration is a fancy way to say it. So your blood pressure is lower on inspiration, okay, than expiration. A narrowed pulse pressure is the difference between systolic and diastolic. So you know, normally, let's say 120 over 80. Let's say 120 over 80. That pulse pressure is 40, okay? Now I have a pulse pressure of 100 over 80. That's 20, right? 100 minus 80 is 20. So now we have a narrowed pulse pressure. We have a narrowed pulse pressure. That's another sign of cardiac tamponade. So you're going to say, well, wait a minute. Why are we increasing volume? We're really trying to stretch those ventricles to get some sort of cardiac output, plus they're hypotensive. So we're going to blow fluid in them. We want that heart to sort of push against that tamponade and help stretch those ventricles to get at least some sort of cardiac output. They're going to get hemodynamic monitoring, so they're going to be in the ICU. Pericardiocentesis, I got to tell you this. So I'm working midnight shift, you know, in the ICU. Cardiologist comes in, decides that this patient has pericardial effusion. Very serious, very quick. Takes this big long needle and legit shoves it in his heart and drains off the fluid. Now I'm about ready to poop my pants in the corner because I was like, wait, what? So he put him on, like, he had him on hemodynamic monitoring, and see, if you look at this picture over here, he literally stuck the needle in and drained out the fluid. I was like, wait, what? What? I mean, I couldn't believe, 3 o'clock in the morning he's doing this. And then the patient went down for the window, so they'll cut out that section to allow for that fluid so it doesn't build up again. But it was emergent, so he stuck that needle in. I was like doing a Hail Mary in the corner. I was very, very scared. That is an emergent procedure, and certainly you can puncture the ventricle, cause bleeding. I mean, there's so many complications along with the pericardiocentesis that, I mean, he was brave. I was like, not a chance. I was very, very nervous. So he drained off that fluid, sent it for analysis. So he cultured it to make sure it was not infectious, that it was only inflammatory. Because if it's infectious, then we've got to treat that microorganism. In the pericardial window, part of the pericardium is removed. Part of the pericardium is removed. That's that outside layer to allow for free flowing, so the fluid can drain. in that lymphatic system that I was talking about, the body would reabsorb it. And then the pericardiectomy is like actually removing that tough, scarred, maybe if it's a chronic situation, removing that section of that scarred, tough pericardium to be removed. I've only seen this pericardiocentesis once, and once was absolutely enough for me. All right, rheumatic carditis. So we're looking at a patient who probably had an upper respiratory infection with strep, maybe a strep infection, strep throat, and then it went into rheumatic fever, and now the heart is inflamed, all layers of the heart. Massive inflammatory reaction in these Aschoff bodies. I'll show you a picture, I think in the next slide. There's nodules and then scar formation in the myocardium. And when we have scar formation in a muscle, it doesn't contract effectively. So if you look below, impaired contractile function, okay? And then the mitral and the aortic valves may have vegetations on. So now we're talking about infectious endocarditis as well. And these patients may end up with pleural effusions as well. So what does this patient look like? They're going to be tachycardic. Their heart's going to be enlarged. There might be, they might be a new or changed murmur. It's maybe a pericardial friction rub. They're going to have pain. There's going to be changes in the EKG, signs of heart failure. And then do they have an existing strep infection? Did we get a positive throat culture that showed strep? Is there a strep antigen in the urine? I don't know if you've ever looked for that. When physicians send strep antigens in the urine to see a recent strep infection. Do they have perhaps community-acquired pneumonia that was caused by strep? So what do we want to do? Well, the primary prevention is to treat all strep infections, whatever age, young, old. Signs of infection, you can see high temp, sore throat, lymph nodes, abdominal pain, a red throat with exudate. Once rheumatic fever is made, start antibiotics immediately. And strep throat, penicillin is the drug of choice. So it would make sense that if this is a strep infection, penicillin is the antibiotic of choice. Now, don't raise your hand and say I'm allergic to penicillin, because I am. We can use other medications, but penicillin is the drug of choice unless it's contraindicated. Everybody got that? So antibiotic prophylaxis necessary for the rest of the patient's life to prevent infective endocarditis. And reinfection from a strep infection is possible if it affects my valves. I may need a valve replacement or repair. If it affects my valve, I may need to go to surgery. And they'll see that on the 2D echo. So they'll see how well those valves open and close on the 2D echoes. So again, primary prevention, treat all strep. You start having a sore throat and you've got a high fever, take those antibiotics. Again, if the valve dysfunction, now we're looking about, because if the valves don't open and close appropriately, fluid can back up. So if I have a really dysfunctional valve, I can go into heart failure, or if I have vegetation on that valve, we can throw little microemboli. We can throw little microemboli, or it can cause dysrhythmias or arrhythmias, whatever you want to call it. We can cause dysrhythmias or arrhythmias. So you really, really want to know if their valves are dysfunctional. That's really about it on the itises. So let's talk maybe a little bit, I'm just looking at time here, a little bit about the cardiomyopathies And then I'll save maybe just the rest. The rest is like questions. We have a case study. So what we might do is like do a little bit on cardiomyopathy, and then we'll stop for today, and then we'll do the case study and maybe just review a little bit for the cardiac test on Thursday. Okay. All right. So there are 4 different types of cardiomyopathies. So dilated cardiomyopathy, most common, and pregnancy, heavy alcohol, viral infections, maybe chemotherapy, systolic dysfunction, and poor nutrition. So those could be the causes of dilated cardiomyopathy. Hypertrophic, and again, if you think about it, so your brain says dilated cardiomyopathy, so the heart's enlarged, okay? That ventricle's probably enlarged. Hypertrophic, the muscle is thicker. So think of like when we're lifting weights and we're building muscle. Hypertrophic, rare autosomal dominant condition. Restrictive or constrictive is diastolic dysfunction. Amyloidosis, idiopathic, it's a poor prognosis. Arrhythmogenic, right ventricular cardiomyopathy, autosomal dominant condition, affects young adults. All right, so here's some pictures. So see the dilated, how big the ventricular chamber is? Very big, okay? And if you look at hypertrophic, do you see how small the chamber is and how big that muscle's built up? And then restrictive looks a lot like hypertrophic. It's a more rigid ventricle, okay? Take a look at the size of the heart. Take a look at the side. I mean, it's all the way over to the side of the rim. So if we were assessing this patient and we didn't know that they had cardiomyopathy, your PMI would be displaced all the way over into the armpit. That's what we're talking about, that displaced PMI. And again, hypertrophic, think of that muscle's built up really, really large. It's had to work very, very hard. Any other muscle you're building up. Here's restrictive, looks large as well, and very hard for that ventricle to contract. Very hard for that ventricle to contract. So any of these cardiomyopathies, you guys, it's a disease of the cardiac muscle. Any of these cardiomyopathies are a disease of the cardiac muscle. And it either enlarges or thickens or makes it rigid. And like one of the things when we talked about coronary artery disease, there's something called an ischemic cardiomyopathy. And that's an enlarged heart due to the lack of blood flow through the coronary arteries, a whole nother thing. So ischemic, if you've read that before, ischemic cardiomyopathy, an enlarged heart caused by coronary artery disease. So it's a lack of that blood flow. That heart's starving for oxygen, okay? So again, just another little fun picture if you're a visual person to see. Again, just showing you see how restrictive. The hypertrophic and the restrictive look very similar as the size of the ventricles, but the restrictive are more rigid. Okay, more rigid. Arrhythmogenic, very kind of rare. This is when you see sudden death in young athletes. People just, running and they just pass out and die. So sudden death in young athletes, it's a right ventricular aneurysm. These patients have ventricular arrhythmias. So VTAC, VFib.
Is that that video that you posted about that boy?
What video did I post?
I don't know. There was videos on like cardiomyopathy and stuff, and there was a kid that was playing soccer and they thought he had asthma. Do you know what I'm talking about?
Yeah, that was probably Debbie's video, so I have to go watch it, but
Okay,
yes.
sorry.
Yeah, no. Yeah, I always share whatever she shares for the fall class. But yes, to answer your question, Dawn, so this is that really healthy athlete that just dies and you're like, what the hell just happened? It's sudden death because VFib may be the first presentation. This patient may never have had an echo, never knew that they had this cardiomyopathy. And the first presenting sign can be ventricular fibrillation and they die. And you're like, what the hell just happened? So I guess, Dawn, yeah, that sounds like the soccer player. I'm guessing.
It's only like a 3-minute video. I mean, it was interesting, but yeah.
That would make total sense. Or somebody that's, been healthy and they just boom, go down. And you're
Well,
like,
he didn't die though, just so you know. He didn't die.
okay, good. I'm happy about that. These patients need antiarrhythmic medications. If we know it, antiarrhythmic medications. Or they need a defibrillator. So they'll get an implantable defibrillator because they go into these fatal arrhythmias. So they'll either be on antiarrhythmic medications for ventricular arrhythmias, which are life-threatening, or they'll have an automatic defibrillator, which is implanted like a pacemaker. So it shocks the heart back into a regular rhythm. Very scary. Very
Did you
scary.
say antiarrhythmic meds or a pacemaker?
Not a pacemaker, a defibrillator.
Okay.
So it'll shock. When you guys go to basic life support and you're like, I am attaching the AED. They'll have that implanted. It looks like a pacemaker. So an implantable cardiac defibrillator. It looks like a pacemaker, but it actually shocks the heart. It recognizes that the heart is in a fatal arrhythmia and it'll shock the patient back into a normal rhythm. So
Lorraine, would they
Yes.
feel that?
say it again.
Would they feel that whenever it's
Oh, hell yes. So yeah, I mean, if it's, let me back up. If it's VFib, they'll be unconscious because you don't have a cardiac output with VFib. If they're in VTAC with a pulse, yes, they can. I've had patients come in and say, my defibrillator keeps firing and it keeps shocking them. So yes, they can and will feel it, yes. Unless they're unconscious in VFib and they need life-saving measures, so we got to do it. Make sense?
Yeah, thank you.
Good. Okay,
I mean, I have a question.
yeah.
So are those defibrillators, I don't know why, but are those defibrillators, are they MRI compatible or no?
They are, because I don't think they're made of like whatever metal you can't have in the MRI. They might be made of titanium or something along those lines, because I've sent people with pacemakers and defibrillators into MRI. All right. So what do they look like with any cardiomyopathy? They're tachycardic and they're going to have an S3 or an S4. PND, does anybody know what PND stands for?
Paroxysmal nocturnal dyspnea.
Yes, so I'm minding my own business, sleeping like a log, and I wake up short of breath. I'm awakened by shortness of breath and coughing. Absolutely, absolutely. Okay, cough with exertion. Orthopnea means I got to sleep up on 16 pillows. Fluid retention, so they're going to have edema, they're going to have crackles. Chest pain, palpitations, so they're very common for any cardiomyopathy. Now the dilated, the restrictive signs and symptoms of heart failure. Dyspnea on exertion, or DOE, dyspnea on exertion. Dyspnea on exertion and fatigue may lead to severe heart failure, dysrhythmias, and death. We already talked about the ventricular tachycardia, the arrhythmogenic down on the bottom. They're gonna have a left bundle branch block with ventricular tachycardia, could be VFib. Could be VFib. Remember, these are the patients that need the implantable defibrillator. And then the hypertrophic, maybe cardiac arrest is the first symptom of it. Okay, regardless of the cause, severe heart failure, lethal dysrhythmias, and death can cause. So right here, regardless of the cause, any one of those. So what are we gonna do? We're absolutely gonna do a 12 lead because we're gonna look to see what kind of rhythm the patient has. What kind of rhythm are they in? Are they in VTAP, VFib, AFib? What is their rhythm? 2D echo. Is that going to show me that the ventricle is not contracting or it's enlarged? What does the ventricles look like in the 2D echo? What does the valves look like in the 2D echo? Is the heart contracting appropriately? That guy's on a 24-hour Holter monitor. Chest x-ray is going to show me cardiomegaly. It's not going to tell me what kind of, cardiomyopathy, but it's going to show me an enlarged heart. Chest x-ray is going to show me an enlarged heart. Cardiac catheterization definitely can tell us how well the valves are functioning, coronary arteries, and how well that ejection fraction is. So it can give us an ejection fraction as well. And if there's any kind of coronary artery disease, as well as the cardiomyopathy. So it can tell us how well those coronary arteries look. Cardiac MI, MRI, not MI, MRI. We can take a look at that muscle and get a great picture of slices of what that cardiac muscle looks like. Biopsy, if we don't know what's causing it, go in there and take a chunk of that cardiac muscle. And then electrophysiologic testing. So cardiologists, bring them in, maybe do some stress tests, take a look at that as well. You got to rule out other causes of heart failure as well. Do they have left-sided heart failure? Are they right-sided or cor pulmonale? So really ruling out other causes of heart failure as well. So what are we going to do? We're going to improve cardiac output and peripheral blood flow. So sitting up with legs down. Oh, there we go again, decreasing that preload. Giving them oxygen, providing rest. In hypertrophic, you need to avoid dehydration and diuretics and ditch. So in that one in particular, you don't want to give them excessive amount of diuretics. You don't want the patient to become dehydrated. They need to have appropriate volume to help with that cardiac output. And digoxin's not a choice for that. Increase activity tolerance and improving gas exchange. Again, pacing your activity and rest. Avoid strenuous activity. And then always, I don't care which type of cardiomyopathy, are they orthostatic when you get them up? Do you see? And orthostatic is perhaps they have a decreased cardiac output with movement. So now we're assessing, do they have a decreased cardiac output with just getting them up? Just that movement, okay? Reduce anxiety. So definitely educating the family. And if it's significant enough, maybe educating them about what their future looks like and maybe palliative care, depending on how significant it is. Correcting heart failure associated complications. So if I'm in AFib, with my cardiomyopathy, I have the potential to throw blood clots. And if I don't have a great, and the blood's kind of stagnant, I can get blood clots that way. So patient may be on Coumadin, heparin, Lovenox. We want to prevent blood clots. Dysrhythmias, we want an antiarrhythmic such as amiodarone. I think we had you guys look that up this semester. Amiodarone, you'll learn about the antiarrhythmics more next semester? Do we need a pacemaker to override what that rhythm is? Or do we need that ICD is the implantable cardiac defibrillator? Now, I can have a pacer and an ICD in one little apparatus. I can have them both. So depending on what the patient needs. With the HCM and DCM, so dilated and hypertrophic, they'll need a pacemaker. If we're worried about sudden cardiac death, we're going to put them on, there's your amiodarone, that's that antiarrhythmic. Only drug shown to reduce the incidence of sudden death in that young soccer players situation. So those patients that I said that need antidysrhythmic, that amiodarone is the drug of choice. Amiodarone is an antiarrhythmic. It's a class 3 antiarrhythmic. That's the drug of choice. There's a lot of complications to taking amiodarone, which are, hopefully you did the med card and looked it up, but and we'll learn about it more next semester, but that is an antiarrhythmic. Decreased workload of the heart, all those drugs that we talked about, ACE inhibitors, diuretics, hypertrophic, we're going to do beta blockers, especially if they're tachycardic, antidysrhythmics. Positive inotrope, that DIDGE that I talked about, we want to increase contractility. We do not give DIDGE with hypertrophic. So with HCM, we do not give DIDGE or vasodilators. We're going to treat with beta blockers or calcium channel blockers. We're going to treat with beta blockers or calcium channel blockers. Absolutely no DIDGE. And then low sodium diet and a fluid restriction as well, especially if they're fluid volume excess. Surgical management depends on the type of cardiomyopathy. Most common is this is the implantable defibrillator, the ICD. So if you see that, it will automatically shock the patient if they go into a fatal arrhythmia. It will automatically shock the patient. You don't have to put the patches on them. It does it. Okay. Ventricular myomectomy, they might cut into the ventricle. Okay. Percutaneous alcohol septoablation, they'll go in and actually try to burn, scar an area so that it doesn't throw into those fatal arrhythmias. An ablation, I'm sure you guys have heard of that. They'll try to stop that fatal arrhythmia. They'll go in. Don't worry about the alcohol septal, but ablation actually goes in and scars that area that is the potential for an arrhythmia. And then last,
Lorraine, I have a quick question about
Fire.
that defibrillator.
yes.
So if the patient does like go into one of those fatal arrhythmias and then like say they become unconscious from it, would it catch it before that point? I'm just kind of thinking in the fact of doing like CPR, would it travel through their skin and shock whoever's doing the CPR? Or would
That's a really good point. So okay, you got two questions there. So first is, hopefully that's why we got the implantable cardiac defibrillator, that we don't even have to do CPR.
Okay.
So let's start with ideal situation.
Mhm.
I go into this fatal arrhythmia and boom, shocks me. And VTAC, it knows how many beats before it'll shock the patient. VFib, it's just going to automatically shock because there's absolutely no cardiac output with VFib. It's like chaos. So let's start with that scenario. So hopefully, yes. Will it take care of business before we have to take care of it?
Yeah.
You hope. Now, malfunctioning defibrillator, or it's just resistant to the shocking, or the family says, you know what, it shocked them like 5 times today. So they'll, they cut, and they should come into the hospital if it activates. So let's say I'm out to dinner and boom, it shocks me. They should come to the hospital, get a 12 lead and see what's going on. Could it be an inappropriate shock? Maybe, because it's malfunctioning. Or are they in some sort of VTAC, but they haven't lost their pulse? Possibly. They still need to be seen. Now, the issue is, if I'm doing CPR and if I have to do CPR, it's not going to continually shock because now we're compressing the heart, maybe giving medications, and now they're in asystole. So it really depends on what rhythm they're in, I guess. I've never touched anybody that actually shocked. Like I watched somebody eat breakfast and he went, zzz, and he just kind of went like that a little bit, and then he went back to eating his breakfast. Probably had some run of VTAC, didn't even know it, and he went back to what he was doing. But he's like, oh, you know, and he knows. VFib, they're going to be unconscious. They're going to come in. It's going to be a full-blown express team.
Okay.
I don't know if that answered your question.
Yeah, kind of. That makes sense. So I was kind of just curious, like I figured it would catch it before they like the body, like it became like
That is the intention. Let's put it that way. That's the ideal intention is we know that they have fatal arrhythmias. We've already identified it. Now we're putting in a defibrillator so that they don't have to worry about being out at, you know, Dairy Queen and just going into a fatal arrhythmia. It's going to shock them. 100% need to come in if that happens, because we need to check them out and see, is the potassium low? Is there another reason why they're in that fatal arrhythmia? So definitely need to
makes
come
sense.
in.
Thank you.
All right, so what I think I'm going to do, this case study, I am going to stop here. And what we'll do is we will pick up with the case study and any questions that you'll have on Thursday. Can I answer anything before we go to sleep?
Dr. Comer, I got a question about that defibrillator. I swear there was like a time that when I was working on the OBS floor over in Boardman, there was a patient that was brought in, and I almost like, I don't know if this sounds right though, because then like I didn't know, but they were saying that they were getting shocked, like he had an implant. So could that do the same thing, like just generally like keep shocking him? Because I know they had to come in and I don't know, it was like a gray thing and it had knobs kind of on it that they had to like fix something. I don't know how.
Oh, they put him on a pacemaker? Because the great thing with knobs is an external pacemaker.
I don't.
Two different things you're saying there, Lisa. I think so. An external pacemaker, if I need to pace the heart because of whatever reason, maybe my heart rate's 20. If it's external, you're going to see them pacing. You're literally going to see that they're going to move externally. Once they get an implantable pacemaker, you won't see that because the little wires are connected to the little ventricles or atria, depending on what type of pacemaker, and do it internally. But maybe, because when you're talking about a little gray box with knobs, that sounds to me like an external pacemaker, and you'll literally see them twitch. It's not necessarily shocking the rhythm, it's helping the ventricles or atria, depending, contract. The shock is if we defibrillate because of a fatal arrhythmia. Pacemaker external, big patches like we were teaming them, and they'll literally, if you crank up the strength of the pacemaker, you'll make the whole body twitch.
I want to say it was like a green circle, but like, I don't know, maybe I'm getting like they're like a patient like mixed up, but I know one that they came in with, it was like a gray disc almost, and like they put it and turned it, and that might have been something else. But I do know that the one time that this patient came in, like he would like almost go like jumping. I want to actually say it was one of Leah's patients that he like, that they weren't sure like what was going on with them, and then they called the cardiologist in. But I don't know, like that's why I'm asking if you could get shocked with one of those.
So not the pacemaker won't shock, it helps regulate the rate. Now, there are defibrillators that malfunction. I've taken care of several patients who like it kept shocking me in the grocery store. I'm like, okay, they need to come in and get a new defibrillator. So that is a possibility. Without seeing what piece of equipment you had there, I can't answer. I know, I'm sorry.
I might have got it mixed up. So either or, you answered both of them if it was the case. Thank you.
Yep. Yeah, and you'll learn more about pacemakers next semester, and you'll actually see them in the ICU. It's kind of, well, it's kind of cool. So, you know, to see how they work and how they function and really how they help the patient. So you'll definitely learn about those next semester. So Bernie, you asked about, does a life vest work the same way? I think I'm not real well versed in the life vest, so I don't want to answer the question. My girlfriend actually places those on patients. I don't know exactly the whole premise, so I don't want to give you the wrong answer, but I will investigate that. My girlfriend actually trains the patients to wear them. She's one of the directors at St. E's, and I will reach out to her and get the correct information for you. Anything else?
Yes.
What? Yes.
What?
What?
This goes back to the manifestations of constrictive pericarditis. And you said it's diastolic heart failure, correct? Why is it diastolic heart failure?
Because it doesn't allow for the ventricle to fill. Remember that diastolic heart failure has to do with the filling process. Systolic heart failure has to do with the contraction process.
Okay.
So when it's like, impeding, it doesn't allow to fill appropriately. So that would be diastolic.
Okay. I was just like, you were going through it and I didn't want to like interrupt you again. So I just put a question mark by that. And so, okay.
Yeah, very good. Anything else?
I have a question about the previous lecture.
Okay.
It's a real simple question.
Yes.
So I had met with the tutor yesterday, not Samaya, but Kim, I think her name is. So we was going through it and we was talking about Zetia, and she was like, it increases your HDL. But she said that can't be a good thing, but I thought your HDL needs to be high.
The better, remember, the higher the HDL, the better. The lower the LDL, the better. So I connect the H's with the H, the L with the L.
That's what I thought, but I just want to double check with
Who's
you.
Kim? Who the hell's Kim?
I think she's from Toledo. Her name is Kimberly Dion.
I have no idea who that is. Okay.
And it was just weird because she asked me what I wanted to go through, and I told her, and when she was going through the lecture, it was like that was her first time looking at it.
Oh, yeah, I don't know her.
Yeah, it was kind of weird. She
Yeah,
said
they said they were getting another tutor, but.
Oh, okay. Yeah, so the higher the HDL, the better. It's more cardioprotective. Remember, I bragged about that. Okay?
Right.
The lower the HDL, the better. Is Kim's an imposter? Yeah. She's from Arizona.
Arizona.
Oh, okay. I don't know her. I've not.
She
met
used
her.
to be an instructor, she told me, but I didn't ask where.
Okay, I don't know her. I'll have to reach out and see who the heck she is. But yeah, you want the HDL higher.
Okay, that's
more cardioprotective.
Mm-hmm.
Okay, definitely. LDL is the bad stuff. The lower, the better. Less than 100. Remember that.
Right.
And the HDL greater than, I don't know what, 45, 50. I mean, I'm double that, so whatever. You know what I mean? but yeah. So the higher the HDL, the better.
All right. Thank you.
You're welcome. Anybody else? Okay, so all we got to do is the case study, and you can come with your questions. We can talk about cardiac, all you want.
Mrs. Colmer, I have a question though, but I don't want to hold everybody else up. Like I can wait till they're done and stuff.
Is it content related? Because maybe they want to know.
Well, yeah, but I feel like some people probably already know this, but I feel like, I don't know why, like the last time we got together, I just was in like a weird zone. So like some things just were not sticking. Like today is better, but I feel like I kind of got like, you kind of said it to Tammy for a second about the left-sided and right-sided. And I just want to make sure I kind of have that simply straight in my head because it is a blur last time.
So one of the things that I would really recommend for you guys, and you'll use this in next semester as well, is understanding the flow through the heart, understanding where everything's at, so right atrium, right ventricle, pulmonary artery out to the pulmonary system, back in through the pulmonary vein into the left atrium, left ventricle. So if you understand the flow and where things are sort of connected, then you get that if my left side of my heart is failing, everything's going to back up into my lungs. Okay.
Okay. Yeah.
My lungs. Versus if I have right-sided failure, it's coming from the lungs, backing up into the right side of the heart. Okay. So pulmonary issues, restrictive lung disease, significant COPD, a massive PE, essential pulmonary hypertension, anything that causes resistance in the pulmonary system, it's going to back up into the right side of the heart. Then you have right-sided heart failure. Can someone who has left-sided heart failure eventually end up with right-sided heart failure? Sure. If I'm significant enough that I've had this go on for years and it backs up, it's all connected, you guys. So it's going to back up from the left side into the pulmonary artery, into the right side. It's all connected. They just differentiate because if I'm in an acute episode of like I had a left ventricular MI, my left side's failing. Or if I'm a sleep apnea patient, my right side's failing. So that's why we differentiate those. I don't know if that helps.
No, it's okay because to me, I'll just be able to figure the pulmonary, all the right, and it'll be all that kind of stuff going on, and I'll be able to flow through it better.
But remember, it's all connected. So
It's all connected
yeah.
though, yes.
Some point in time,
Mhm.
that left-sided heart failure can be significant enough to go all the way back into the right side
Right.
and have biventricular failure.
And
you
then
both
like,
have failure.
I think it was like also with the peptides, I might have, that's just another medication that,
Are you talking about the lab value, the brain natriuretic peptide, the lab value that's diagnostic for heart failure? Or are you talking about Natricor?
maybe that's what it is.
Okay, so Natricor is that IV medication that helps with natural diuresis, natriuresis. So that we give that in very acute, that's an ICU. We don't give that on a general floor. So that's an IV medication, continuous IV medication drip that we give to help that patient in acute heart failure.
Okay.
Good. So I would definitely recommend, we've covered all the content. So
Mhm.
now you've got a couple days to sort of process. We'll do the case study when we come back. You have some time to sort of think about things and come back and ask those questions when we meet on Thursday. Does that sound like a plan?
Yes, I'm good. Thank you.
Okay. Anybody else? Okay, well, I'm going to stop recording.
Thank you, Dr.